Hi everybody, this is Dr. Mark Riggs with 5280 Functional Medicine, and this presentation is all about vitamin E. Vitamin E is a fat-soluble vitamin like vitamins A, D, and K, and unlike the B vitamins and vitamin C, which are water-soluble vitamins. The most biologically active form of vitamin E is D-alpha tocopherol, so we have two forms of vitamin E, tocopherol and tocotrienol. And there are different subtypes of tocopherol, such as alpha, beta, delta, and gamma. So make sure you check your food labels. We want a spectrum of these different forms with an emphasis on D-alpha tocopherol, since that is the most biologically active. The other form of vitamin E are tocotrienols, found in legumes, grains, wheat germ oil, and wheat bran. Here's a food label that shows vitamin E, and in parentheses it says D-alpha tocopherol acetate. Here's another food label, vitamin E, in parentheses, as D-alpha tocopherol. 400 international units of vitamin E in one soft gel taken daily is a good dose that we recommend many of our patients take. But as you can see, it says that's 1,333% of the recommended daily intake of vitamin E, because the RDI typically is there to avoid acute disease. It's the amount of this nutrient to avoid acute disease. And here we're taking 400 international units, which far exceeds the RDI, but we're taking supplemental vitamin E not to prevent acute disease, but to actually promote health and wellness. The best food sources of vitamin E are plant sources as opposed to animal fats. The richest sources of vitamin E are found in plant oils such as corn, soybeans, safflower, and cottonseed oils. Now, these are not the healthiest oils that we could be consuming because they're so highly inflammatory, but there are other oils that contain vitamin E, such as wheat germ oil, almond oil, flaxseed oil, olive oil. We can also increase our intake of almonds, hazelnuts, walnuts, pecans, oats, brown rice, sweet potato, and spinach, just to name a few dietary sources of vitamin E that are much healthier than corn and soybean, safflower, and cottonseed oils. Since vitamin E is a fat-soluble vitamin, it requires dietary fat to be taken with it for optimal absorption. Dietary fats stimulate pancreatic enzyme release and gallbladder contraction, so this requires sufficient pancreatic function and a gallbladder. Lots of patients are having their gallbladders removed, and this interferes with their ability to break down and absorb and assimilate fats and fat-soluble vitamins. Vitamin E also interacts with other nutrients, most notably vitamin K. And this is why it's very important to be careful with high-dose supplementing of any one particular fat-soluble vitamin. We recommend that our patients supplement with fat-soluble vitamins all in combination with one another, and not to emphasize one fat-soluble vitamin far more than the others. And the reason for this is because emphasizing one, in this case, if we emphasize vitamin E, and we take that in high doses, it actually competes with the absorption of all the other fat-soluble vitamins, including A, D, and K. And with regards to its effect on vitamin K, this can actually have a blood-thinning effect. And now maybe there are situations where we would like that blood-thinning effect, but where we would not like that blood-thinning effect and its competition with vitamin K may be right prior to undergoing a surgical procedure, because it may increase your risk of bleeding. Or we wouldn't want that after a heart attack or a stroke and your doctor's prescribed you Coumadin or warfarin, which are blood thinners. We wouldn't want to emphasize vitamin E in very high doses, because that is going to have a synergistic effect with those previous drugs that I mentioned. Vitamin E is found within the cell, primarily in the cell membranes. It's stored in many tissues, but concentrated more so in our fat tissue. And the storage form of vitamin E is then slowly released during periods of low intake, as is the case with many substrates in the body. Functions of vitamin E include maintenance of cell membrane integrity. Vitamin E actually protects the membranes from destruction and has the ability to prevent peroxidation of unsaturated fatty acids in the cell membrane. It also inhibits heart disease and stroke by decreasing LDL oxidation, monocyte endothelial adhesion, oxidized LDL uptake by macrophages, smooth muscle hypertrophy, decreased platelet aggregation and adhesion. It increases nitric oxide production and modulates prostaglandins PGI2 and TXA2. It's also been noted in a meta-analysis of cohort studies that there was a significant negative association between vitamin E status and coronary artery disease. This means that as our vitamin E status goes up, our risk for coronary artery disease goes down, and vice versa. As our vitamin E status is worse, our risk for coronary artery disease goes up. Now, it should be noted that this vitamin E status is based on our dietary intake of vitamin E, not our supplemental intake. Vitamin E also helps inhibit cancer and inflammation by decreasing the activity of protein kinase C and nuclear factor kappa beta, leading to decreased smooth muscle cell proliferation, decreased tumor cell growth, decreased inflammation, and increased controlled cell death or apoptosis. Vitamin E also has a link to prostate cancer. It's not associated with reduced total mortality, cancer incidence, or cancer mortality, but it is associated with a statistically significant reduction in the incidence of prostate cancer. This means that vitamin E can and should be used in the prevention of prostate cancer in men who know they're at high risk. Switching back over to tocotrienols, this form of vitamin E reduces cholesterol synthesis, suppresses tumor cell growth, and prevents glutamate-induced neurotoxicity, which is potentially beneficial for Alzheimer's and Parkinson's patients. Now, so far I've only talked about the potential benefits of vitamin E and supplementing with vitamin E. Next, we're going to talk about the drawbacks that have been established according to the research. The research states that there is no evidence that supplemental vitamin E can prevent heart disease based on clinical studies and large interventional trials. However, as I mentioned earlier, dietary vitamin E status absolutely does reflect our risk for coronary artery disease. Also, as I mentioned earlier, supplemental alpha tocopherol may increase bleeding tendencies due to its inhibition of vitamin K. In a 2010 meta-analysis of randomized trials in the British Medical Journal, researchers concluded that supplemental vitamin E increased the risk for hemorrhagic stroke by 22% and reduced the risk of ischemic stroke, the more common type of stroke, by 10%. And this is both due to its quote-unquote blood thinning effect via the inhibition of vitamin K. So therefore, indiscriminate widespread supplementing is cautioned against when it comes to vitamin E, because you don't know what camp you're in. Now here's a drawback that really took me aback. A meta-analysis of the use of high dose or greater than 600 international units of vitamin E supplementation was documented in the Annals of Internal Medicine in 2005 and revealed an increased risk in all-cause mortality. That means when you take more than 600 international units of vitamin E supplementally per day, you are actually at an increased risk of dying from all causes. Unbelievable. Potential health benefits of alpha tocopherol supplements may be offset by the negative effects of decreased bioavailability of other forms of tocopherols and tocotrienols if you're only focusing on just the alpha tocopherol form. This is why, again, it's important to supplement with a mixed tocopherol supplement. Patients prone to vitamin E deficiency include alcoholics, poor and incapacitated elderly, patients with serious diseases that affect appetite, the mentally handicapped, and children receiving inadequate care. Deficiency in vitamin E is very rare because vitamin E is found in a lot of the foods that we eat. Therefore, if we know that a patient has vitamin E deficiency, we would need to investigate whether or not the patient has a fat malabsorption disorder, such as cystic fibrosis, or a cholestatic hepatobiliary disorder, such as hepatitis, alcoholic liver disease, or primary biliary cirrhosis. It might also be necessary to investigate whether or not the patient has a genetic defect of alpha-tocopherol proteins or of lipoprotein metabolism. Symptoms of deficiency of vitamin E include muscle pain, weakness, hemolytic anemia, degenerative neurological diseases including peripheral neuropathy, cerebellar ataxia, and loss of coordination of the extremities. The opposite of deficiency is excess or toxicity of vitamin E. And as I mentioned previously, high doses of vitamin E by itself can interfere with the absorption of other fat-soluble vitamins. It can increase the patient's risk for bleeding as it interferes with vitamin K's clotting mechanisms. Toxic levels of vitamin E are associated with gastrointestinal distress, and in more rare cases, muscle weakness, fatigue, and double vision. In order to avoid that increased risk of bleeding due to toxic levels of vitamin E, it's recommended not to exceed 1,500 international units of supplemental vitamin E in the form of alpha-tocopherol. However, as stated earlier, if you want to avoid your risk of all-cause mortality, you would want to limit your upper intake of vitamin E per day to less than 600 international units. And that is all I have for you for vitamin E. This is Dr. Mark Riggs with 5280 Functional Medicine in Aurora, Colorado. If you liked this video, feel free to explore the rest of our educational resources on www.5280functionalmed.com. Thanks for listening.